So I'm here with Stefan, presenting the result of the discussion for the physical group. And well, we did the dream study thing that you talked about and didn't do. So we're gonna continue that. So this study is inspired by other clinical settings where you have a predictive score to predict an outcome or the risk of a disease. And we know that several factors, cancer and diabetes, are linked. But we thought that maybe if you combine some of these biomarkers and risk factors, then you can get a score that could work very well as a prognostic factor. And we chose one of the populations we chose are patients with treatment-naive breast cancer. So this is the risk of diabetes in treatment-naive patients with breast cancer. Our research questions were which risk factors and biomarkers predict the development of diabetes in treatment-naive breast cancer patients, and is it possible to develop a risk score to predict which patients develop diabetes? And secondary outcomes, if we're lucky, maybe we can identify which of these cancer patients later develop diabetic complications. And we plan on designing two different studies. Firstly, we would like to do a retrospective study with data analysis from the Danish patient registries. And we wanted to identify risk factors in patients with breast cancer patients to see which of these develop diabetes. We wanted to do a case control study, but in our case, the control population would be patients with breast cancer that did not develop diabetes, and comparing them to patients with breast cancer that did develop diabetes. And some of the things that we wanted to look at were HbA1c and CRP, sarcopenia, maybe based on the baseline CTs, BMI, if we could get that, visceral fat distribution, also from the CT or PET CTs, familial disposition, prednisone during treatment, type of cancer treatment, form status, comorbidity, medication, alcohol and smoking history, and a history of gestational diabetes. And also, we would like to look at diabetic complications, survival, recurrence of disease, secondary cancers, and hospitalization rates. So from this retrospective study, we hope to find a few markers that are more evident in patients, breast cancer patients who do develop diabetes. And then we would like to take these markers further and do a prospective study. And in this prospective study, we wanted to include treatment-naive breast cancer patients. And before they get that treatment, we would like to obviously measure all the previously mentioned markers that we identified in the retrospective case control study. Also do oral glucose tolerance test, GRIP test, DEXA, do fecal samples to examine the microbiome, and fasting blood samples and biopsy during surgery of fatty tissue, muscle, and tumor. And Stefan will talk about what kind of analysis will be for these.
Thank you. Yes, so hopefully in this perfect study that will be easy to conduct, hopefully we could get some biopsies. And then we would take these biopsies also, especially we talked a lot about the tumor cells, and then we would grow them, and then we would look at the RNA-seq, we would look at secreted factors, and we would also have blood plasma where we could do lipidomics, proteomics, peptidomics, and try to get an overview of which patient that actually have certain markers that leads to the development of diabetes later in their life. So hopefully if we do this big screening, mostly omic and RNA-seq based, we would be able to identify markers that could be taken into the clinic. So if we could get a blood sample or when they operate the tumors out, they could do an RNA-seq on the tumor itself. And then hopefully we would be able to predict who has the highest chance of actually develop diabetes later in life. And it is a longitudinal study, so we would be able to follow these patients for up to 10 years with at different time points we would take blood samples where we will also be able to do these omic-based and RNA-seq-based analysis. Yes. Do we have more?
Yeah. Yeah. So basically, the plan is to combine all these biomarkers with the markers we found in our retrospective study, and maybe find some that combined give us a good risk score for who will develop diabetes in the future. Yeah. That's it. Thank you.
Any questions from group 1, 2? Any comments?
I have a question. So, nice presentation, but I have a question about this prospective study. So, why you don't do a more frequent evaluation of blood sampling and all the other parameters, and then after that, if you find one possible link, then you will try to mimic that into an animal model to see if you can certify this. Yeah, those two questions. Yeah.
Thank you. Very good question. Maybe I can take the mouse thing, and then. So yes, of course, if we find some 1 or 2 or 5 specific markers, we would be able to take it hopefully into a breast cancer mouse model, and if we then introduce cancer cells where we have removed this protein or by siRNA to prevent. If it is a secreted factor, we could prevent this protein, and if we then could follow these with some of the models we've also talked about today that are diabetic, and if we give them breast cancer and so forth, we would be able to hopefully have a more molecular proof of what's going on and not just a marker in a clinical setting. So yes, that's a very, very good point.
And the first question is why we don't plan to do a more intensive blood sampling during follow-up. And that was just a pragmatic decision because our breast cancer patients are followed twice a year in the beginning after treatment. So that would be like when they come to the doctor, they get the blood sample, so they don't have to come for extra visits. But obviously in the beginning when they do get that treatment, they come more often, so there you can intensify the blood sampling and get more data. So,
Thank you very much. I think it was a very nice presentation and an interesting design. I would just suggest in this dream setting, if I remember what you said, you had only planned to measure adiposity through BMI measures. And as we know that BMI is quite a crude measure, and given that the patients come to the clinic, it could be the possibility to actually also include other measurements of adiposity into the study. That would also be a possibility to answer some of the unknowns regarding body fat distributions.
Yeah.
Just a suggestion.
Yeah, I think we plan to do DEXA scan as well, but it's a very good suggestion. In this dream study, we can add whatever we want. Any more questions?
I was just wondering, I'm curious if any one of you have experience with inflammation markers. We discussed it in our group because, as you all know, prior to insulin resistance, we expect an adipose tissue inflammation in the development of diabetes. But does any one of you know how it's best measured in the blood?
I certainly don't, but maybe someone else has a suggestion.
If it's just regular IL-6 or interleukins, TNF-alpha and stuff like that, there are assays, colorimetric assays, where you can measure it. So it's definitely something you could measure by assay that's not a high through output. So you could do other, if we do mass spec analysis, you would also be able to, some of these peptidomics, you would be able to pick up these cytokines in the plasma in a more broader range. Yeah, but there is assays out there. So if you have plasma, you can measure it with the colorimetric assays or fluorometric assays and stuff like that. We do it in our eye studies, at least.
Yeah. So if you were to determine one or two parameters, you would choose IL-6 and TNF-alpha.
CRP.
As CRP, as a whole body inflammation marker. Yes. There's a doctor speaking, so I believe.
IL-6 is usually a quite difficult marker because it can be both pro and con, and it needs to be interpreted into the context of other markers as well. So it's often incorporated into the analysis, but it is a little tricky marker.
Yes.
For sure. I agree. Other comments, questions?
Maybe somebody wants to insert something to this dream study? Yeah? No?
Actually,
Yeah?
it's I don't know if it's necessarily to you guys, but just in general, since we are a diabetes conference, one of the things that I actually find interesting is that type 1 diabetes that has, well, one of the things that we also kind of discussed in our group is like, what are we looking at first? Cancer, then diabetes, or diabetes, then cancer? But I actually found it interesting that people with type 1 diabetes has less of a tendency to, as far as I remember of reading somewhere, less tendency of getting breast cancer as to people with type 2 diabetes. And then again, I'm talking about people that already have diabetes. So in a study like this DREAM study, have you thought about maybe actually going into to differentiate if people that has the cancer first and then developing diabetes, whether it's one or the other? Is it type 1, type 2 diabetes? Maybe it's the latter diabetes version of it, or looking into something like that.
No, we didn't, but it's a good idea. Good suggestion.
I mean, it's just a really interesting thing, because basically type 1 and 2 is kind of two different diseases. So it could be really interesting to see if again, I know it's again this whole chicken egg kind of thing, cancer first, diabetes next, diabetes first, cancer next, but it could be kind of interesting, I think, at least.
Yes, I think you have a good point there. I think at least within type 2, because we know these at least 5 different kinds of type 2 diabetes, some of them presenting with insulin resistance, some another kind presenting with reduction in beta cell function, etc. But I think with type 1, it's different, because they would normally be diagnosed before they have the cancer. The mean age of developing type 1 is much earlier than developing breast cancer, which is as I remember, around 70 years of age. At that time point, we would expect you to have developed your type 1 already, unless it's this very rare form of presenting after immunotherapy or something like that, isn't that?
Well, oh, I can't hear myself. Yeah, definitely type 1 diabetes. Again, I am very new in the whole diabetes, so if there's something that's more of type 1 diabetes, please correct me. But yes, type 1 diabetes is more correlated with getting diagnosed young. However, there are definitely different endotypes of type 1 diabetes, where you also get where you won't get the type 1 diabetes until later on in life. Actually, that I just came out with an article where most of my cohorts that I was looking at, it was actually with people that had gotten diagnosed with type 1 diabetes later on.
Okay, interesting. Yeah, but a good point. Whether it's a special kind of diabetes that they develop, I don't know that actually. Whether we know that we talk about the increased risk of developing diabetes, but I don't know if it has been shown actually if it's a specific kind of these groups of diabetes that they are most often diagnosed with. That could be interesting to look at. Thank you.
And also just in general, like maybe looking at the cohort, if they already have some pre-diabetic biomarkers or something like that for maybe type 1 diabetes, or I don't, it's just, I don't know, I think it could be interesting to look at the different types of diabetes.
Thank you.